Now, the procedures that we're going to use for the cervical spine include manual muscle testing, first of all, of cervical spine paraspinal muscles. And this is particularly useful with regards to a specific injury, especially even a traumatic injury to the cervical spine, which gives us a sense of function not only of the nerve roots that come off of the cervical spine, but also gives us an idea of the function of the cervical spine itself, including the nerves that control muscles that are involved with producing movements of the cervical spine. And I'll go over those unique tests in just a moment. We're also going to be involved with sensory examination of the cervical spine dermatomes. We're going to do motor examination of the cervical spine myotomes. We're going to be testing reflexes in the upper extremity, and then we're going to also be reporting our findings on girth measurements. Okay, so let's talk right now about cervical spine manual muscle testing. With cervical spine manual muscle testing, and by the way, this is just a small section of another program that we have available, which is entitled Manual Muscle Testing and the QME Exam. And just a little philosophy on that program. I don't know if you've noticed or not, but the AMA guides contain many descriptions of manual muscle testing. Specifically in chapters 15, 16, and 17. And so this program, the Manual Muscle Testing and the QME Exam, discusses all the various types of manual muscle tests that we employ in determining permanent impairments related to the spine and the upper and lower extremities. And it's interesting because the AMA guides rely heavily on findings on manual muscle testing for the determination of various permanent impairments, but they don't give us much training on how to do manual muscle testing. So I created an entire program to handle just that issue. With regards to the cervical spine, and we'll just go through this material quickly because I have given this to you in your handout materials. We're going to test the movements of cervical flexion, cervical extension, left lateral flexion, right lateral flexion, and then left and right rotation. And each of those maneuvers involves different muscle groups, either in singly or in combination, which gives us a good idea of the function of many of the cervical spine nerve roots, including some cranial nerves. Well, I should say a cranial nerve, specifically cranial nerve number 11, the spinal accessory nerve. But let me just give you an example. Testing of cervical flexion involves manual muscle testing of the sternocleidomastoid muscle. And the sternocleidomastoid muscle is innervated by the spinal accessory nerve, cranial nerve 11, and also cervical spine nerve roots C2 and C3. So this is an area that we don't typically test with our upper extremity dermatome and myotome testing, but in the event of an injury to the upper cervical spine, this would be a way that we could document injury and or impairment of cervical spine nerve roots. And I had a case in particular where I was able to create a permanent impairment analogy for headaches after a cervical spine injury, and I was able to reference a nerve that's unrelated, at least as far as the AMA guides go, is unrelated to the cervical spine. I created an analogy to trigeminal neuralgia, or injury to the fifth cranial nerve. And this is an example where you could do the same thing with an upper cervical spine nerve root if you're able to document weakness, for example, of the sternocleidomastoid muscle. Cervical extension testing tests the trapezius, the semispinalis capitis, and the splenius capitis. The trapezius, as you know, is innervated by portions of the spinal accessory nerve, also C3 and C4 nerve roots. The semispinalis capitis is innervated by the dorsal primary rami of cervical spinal nerves, and the splenius capitis is innervated by dorsal primary divisions of C4 through C8. So here's a unique example of how we're testing dorsal primary rami, whereas most of our testing, at least as it's described in the AMA guides, involves testing the anterior primary rami. So those of you that have the handout materials or that are watching this on DVD have the reference to all the muscles and all the manual muscle tests involved with the cervical spine. So this is something that you can import into your report and import into your very next examination as well. With testing the cervical spine dermatomes, we're going to use any combination of procedures to test light touch, to test pain, to test two-point discrimination, and then also just remember that in our back pocket we also have testing maneuvers to test for joint position sense, temperature, and or vibration, with most of our focus going to be on the sensory modality of light touch. But I just add the caveat that there are times when we will do examination maneuvers to test for pain and also for two-point discrimination. So with testing for light touch, we're going to start by using the smallest of the Sims-Weinstein monofilaments. That's the 2.83 gauge monofilament. And for testing C5, we're going to test on the lateral aspect of the arm from the summit of the shoulder to the elbow. This is what the AMA guides refers to as the C5 autonomous zone. For testing C6, we're going to test on the lateral forearm. We're going to test on the thumb, on the index finger, and on the radial half of the middle finger. For C7, we test on the middle finger, on the dorsal aspect. For C8, we test on the medial aspect of the forearm, the ring, and the little finger. And then for T1, we test on the upper half of the medial aspect of the forearm and the medial portion of the arm. With testing for pain, we're going to test the same regions, exact same spots, just that we're going to use a different instrument. Okay, so C5 is on the lateral aspect of the arm at the summit of the shoulder. C6 is on the lateral forearm, thumb, index finger, and one half of the middle finger. C7 is on the dorsal aspect of the middle finger. C8 is on the medial aspect of the forearm, including the ring and the little finger, and then T8 is on the medial portion of the upper arm. Now with two-point testing, two-point discrimination testing, this is pretty much going to be reserved for cases that involve injury to the digital sensory nerves, and or carpal tunnel syndrome, and or peripheral nerve injury. But there are cases where you might want to test for two-point discrimination with a cervical spine injury. And according to the AMA guides, normal two-point discrimination is 20 to 30 millimeters on the dorsum of the hand. On the dorsum of the hand. It's 8 to 12 millimeters on the palm, and it's smallest or narrowest at the fingers, with normal two-point discrimination being between 4 to 6 millimeters on the dorsum of the fingers and 2 2 to 4 millimeters on the fingertips. So of course the fingertips have the greatest density and the greatest populations of sensory receptors, so the 2-point discrimination is the smallest on the fingertips. Now the AMA guides do not refer to normal 2-point discrimination in the regions of the distribution of C5 of the C5 dermatome. For example, there is no mention in the AMA guides of normal 2-point discrimination on the shoulder or at the lateral aspect of the upper arm from the shoulder to the elbow. So it's my opinion that 2-point discrimination really, at least as regards to the AMA guides, is restricted and limited only to the hand, to injuries either of the cervical spine or of the upper extremity, as those injuries involve the hand. Now with motor testing, we're going to test the cervical spine myotomes, and we're going to use manual muscle testing. For C5, we test resisted shoulder abduction. And resisted shoulder abduction tests both the supraspinatus and the deltoid muscles. And it could be argued that those two muscles, the supraspinatus and the deltoid muscles, are innervated by different peripheral nerves, and that's true, with the supraspinatus being innervated by the suprascapular nerve and the deltoid muscles being innervated by the axillary nerve. But both of those muscles are almost exclusively C5. They both contain also contributions from C6, but it's minor. So those are almost purely C5 innervated muscles, the supraspinatus and the deltoid. For C6, we test the extensor carpi radialis longus and extensor carpi radialis brevis, which are almost exclusively C6 innervated muscles. For C7, we test the flexor carpi radialis and the flexor carpi ulnaris. So those are both basically the muscles that contribute to wrist flexion. Wrist flexion you can think of as a C7 mediated muscle action. For C8, we test resisted finger flexion. This involves both the flexor digitorum profundus and also the flexor digitorum superficialis muscles. These muscles are innervated respectively by the median nerve and the ulnar nerve, but both of those muscles receive large contributions simply from C8, even though those C8 neurons travel in different peripheral nerves. Those muscles, those myotomes, migrated from the C8 segmental level of the somite, and so those muscles are largely and almost exclusively innervated by C8. For T1, we test resisted finger ab and adduction using both the dorsal interossei muscles and the palmar interossei muscles. With regards to the reflexes of the cervical spine neurologic exam, this is well known to all of you. We test the biceps reflex. That's a C5 reflex, which is carried through the musculocutaneous nerve. We test the extensor digitorum reflex. That's a C6 reflex mediated through the radial nerve. And then we also test the triceps reflex, which is also mediated through the radial nerve. However, rather than being a C6 mediated reflex, the triceps reflex is a C7 mediated reflex. So that's the cervical spine testing. That's quite simple, with the only unique aspect of the cervical spine being that we include manual muscle testing of the cervical spine itself. Now with the thoracic spine is unique and because of the non-migration of the somite derivatives and difficulty in associated with motor testing of thoracic spine myotomes, the thoracic spine exam is actually very limited. Thoracic spine exam includes testing the thoracic outlet, where cervical and thoracic spine nerve roots can become compressed with any of the various thoracic outlet syndromes. It also includes sensory examination of the thoracic spine dermatomes. There is no motor exam for the thoracic spine myotomes, and there is no reflex exam, and there are no girth measurements. So the examination procedures for the thoracic spine are simply limited to thoracic outlet testing and then sensory examination of the dermatomes. Now, a couple of basic landmarks for the thoracic spine dermatomes. If you remember that T4 crosses the nipple line, that will give you a frame of reference for dermatomes above and below that level. T1 covers the area just beneath the clavicles. T4 crosses the nipple line. T7 crosses the xiphoid process of the sternum. T10 crosses the umbilicus, and then finally T12 crosses down into the groin area. Now, you probably won't test those in that direction. You'll probably test the thoracic spine dermatomes from the back. So in that case, it's quite easy to remember that each of the dermatomes follows each of the ribs, with the T12 dermatome coming right below the lowest rib, the T12 rib, the 12th rib. So with thoracic spine dermatome testing, again, we use a Semmes-Weinstein monofilament, 2.83 gauge, and if that is too small to be detectable by the examinee, it may be necessary to use the next higher or the next stiffer monofilament, because sensory receptors are not as densely populated in thoracic spine dermatomes as they are, for example, in cervical spine dermatomes. So with testing the thoracic spine dermatomes, really, what is it that we're testing? We're testing the cutaneous branches of the intercostal nerves, and that's what we call the anterior primary rami of the thoracic spine nerve roots. Those become the intercostal nerves, and then coming off the intercostal nerves are various cutaneous branches that innervate the skin areas in between each of the ribs. Similarly, there are no known reflexes for the thoracic spine, so that largely limits the scope of the thoracic spine exam.